My name is Jason Jones. I'm responsible for data science at Health Catalyst. And as Paul mentioned, we'll be talking about the new and exciting ways that you can have data science in your life. First, we're going to start with a model. And part of the reason for this was Anne-Marie sort of piggybacking on top of the questions my daughter's been asking me for the last 18 or so years, which is, what is it exactly that you do? And truthfully, that's harder to explain than I wish it was. So we've attempted to break it down into 5 levels here. And the part that we're going to spend most of the time on today is that sort of gray or green rectangle section, and specifically the guided analytics section. And within guided analytics, we're trying to make it easier for you to leverage the tools that we use every day and that I wished when I was at Kaiser Permanente I could just buy off the market and they would be easier to deploy across all of our users. These are basic things like statistical process control and forecasting and correlation and risk adjustment. And if you're not sure exactly what these things are, don't worry, we'll go through some examples and some applications of how it is that they can help you and be your friends. But generally speaking, the type of question that we're trying to answer at this first level is what's our trend and what's our time frame to show improvement? How long should we give ourselves? Is this going to take us 3 months, 3 years? How will we know if we're making the difference that we hope to be able to show in the world? At the next level up, we have deploying predictive models. And importantly, you'll see both deploying predictive models and building predictive models are grayed out. And the reason for that is this is the most common question that we get from clients is, help us build and deploy a predictive model. And we love building and deploying predictive models. But it's important to know that you don't have to have a predictive model as part of your solution at all to be using data science. You could be simply trying to figure out where your best opportunities are for improvement, or trying to address another question that doesn't actually require predictive models. So please keep in mind, we love predictive models, but you don't have to limit data science to predictive models. So within deploying predictive models, what we're really talking about is cracking open the black box and making it easier for people to deploy and use these models to lead through the changes that are so important in health and healthcare to make these models matter. At the next level up, we have what most people think of as data science, which is predictive model, machine learning, AI at the point of care service. Help me figure out who's going to get readmitted, help me figure out who's going to get admitted in the first place, be willing to pay, all of these kinds of things. This is the sort of bread and butter that most people think of when they think about data science. And it's important and it's helpful, and we can talk about random forests and neural nets and all kinds of other exciting topics, but it's not all that we do. The reason why this is the first level that is outside of the green self-service area, here our aspiration is to be able to put tools in the hands of non-data scientists to use every single day. Sorry, the reason why predictive models is outside of self-service has actually nothing to do with the technology at all. It's actually pretty simple to teach a computer to build much better predictive models than most, truthfully, than most human data scientists can on their own. The reason that we move it outside of the self-service area is because we find that often it's the best time to ask the question of, do we really understand the problem that we're trying to solve? Do we really understand how, as we're trying to solve that problem, we know whether we're actually helping more than we're hurting? And that's why we move it out of self-service. It's not because of a technical limitation, it's because it causes us to pause and ask ourselves, are we achieving the changes that we hope to be achieving? Next up on the list, and again, we're going to go through examples of each of these, and you'll have the slides after. But next on the list is retrospective comparison. And this is a lot of what Sadaka was talking about previously, and the massive benefits that we're seeing for FDA and others at a national level of how can we leverage our data to answer questions that people have where we're not able to wait 6, 12 months or some longer period of time to develop that sort of gold standard. But we'll see another example of sometimes it's just not possible to randomize people. We can't achieve the gold standards. It's really useful to have a broader tool belt than just statistical process control to be able to ask and answer these questions better using the data that we have already. At the top, we have prescriptive optimization, and this is where you can often think about things like experimental design, and that may immediately make you think, oh, now we're talking about things that other people do. We're talking about research. We're talking about drug companies. We're talking about academic medical centers only. And I would encourage you to not think that way. A lot of the reasons that we have prescriptive optimization and experiments is because it turns out to be the most efficient way to answer the questions. The reason it's at the top is because if we get the design wrong, we can't recover from it. So everything below level 5, if we make a mistake, if we somehow misclassified the target we were trying to predict, if we used the wrong risk adjustment methodology to figure out whose patients were really sicker, we can recover from that after the fact. But if we design our prospective and prescriptive optimization incorrectly, then we're sort of stuck and have to start over quite often. And that's why it's at the top. So these are the 5 levels. I wish we could be in a room together and I could ask, so, is this different from what you expected? What you expected? Where are you in being able to maximize your ability to leverage each of the 5 levels in your own organization? So hopefully we'll get that chance at some point, and please ask questions, but we're not going to be together today. So let's look at a couple examples. The first thing we'll look at is guided analytics. And this is just a practical example of somebody coming to us and saying, gosh, you know what? We have a problem with readmission in our heart failure patients, and we'd like to figure out how it is that we can improve. What will that look like? And on the right-hand side, you'll see 2 different charts. At the top, in the gray section, we have the historic readmission rates for heart failure patients at this institution. And the gray areas are the upper and lower 95% confidence limits, indicating where it is that there's been particularly high readmission rates or particularly low readmission rates over time. You'll see most of the points are inside the gray area, meaning that they're within the normal realm of noise that we would expect. The question, though, is not where have we been, but what's our opportunity to improve and where are we going? And the blue section here is an automated forecast that we can generate out of our guided analytics tools that tells us if history is a guide, we don't have to just make like we're looking up at the clouds and ask ourselves, is there a trend here? Are we getting better? Are we getting worse? We can use the computer to give us a forecast of what the next year is likely to look like from a readmission perspective. And what you'll notice is that the next year is likely to look a lot like past years. There is no trend, but we didn't have to guess. We didn't have to ask people to make up their own minds. The computer could just tell us this as easily as it can tell us who's more likely to be readmitted in the first place. But the other thing that we can do is if we know where we're going, we can ask ourselves, geez, what if we could achieve a 25% reduction in readmission in our heart failure patients? I think most of us would say, wow, that is pretty terrific. That's a pretty impressive improvement. And we can ask ourselves, okay, if we achieve that 25% reduction, how long would it take us to detect that we had made that change? And the answer is about 3 years. And again, we don't have to guess. We don't have to ask people, how long do you think it's going to take? No, we can use the computer to help us do what computers do well, which is crunch numbers, use algorithms, and help us see things that we might not have otherwise been able to see. So we can see we've had pretty flat performance with heart failure readmission. We can see it's likely to continue to be flat, not that we won't have variation from month to month, but overall it's flat. And even if we made a 25% improvement, it would take us 3 years to be able to detect that change given our current variation and the number of patients that we have that are discharged in a typical month. So this is what we mean when we're talking about guided analytics. It's taking the data that we already have and applying standard tools in our tool belt, but being able to do so from patient safety, from care management, from Click, from Power BI, from Tableau, within SAM Designer. These are all things that we're now making available to you in the tools that you already know and love and enjoy using, but now being able to infuse those data science capabilities directly in them. Another example we'll look at is what if we wanted to understand different approaches for looking for outliers in a time series analysis. So we could start on this left-hand side by just displaying a line chart and seeing points going up and down over time. We could apply statistical process control, and if we applied statistical process control in this case, almost every single point lights up as red. Pay attention to me, I'm something worth noting. As humans, we know we can immediately look at this and say, oh, geez, you know what, there's a level here, and then there was an increase, and then it's flat again. I don't want to know about every single point. I might want to know about a couple ones over here. So we could, and we do now, have within our statistical process control guided analytics approach, which you can implement in the tools that you know and love, have something that will take SPC and automatically detect, there's an algorithm to detect that the change has happened. So instead of having someone have to go in and manually annotate when it is that the level changed, we have algorithms that you can use that will let you set it and say, tell me when something has changed in the series, and it will tell you. And this vertical line illustrates where the computer said, not shockingly, there's been a level change and I should recalculate my confidence limits, recalculate my central tendency and everything else. But we have more advanced algorithms in the tool belt that are available to you, like time series outlier detection. And time series outlier detection automatically takes into account some of the things that SPC does not, like seasonality, perhaps month to month, day to day, quarter to quarter, whatever. It automatically takes into account level changes. It automatically takes into account trends. And now we can see it starting to highlight much more usefully some of the points that we wanted to care about. And again, these are things that you can incorporate into standard dashboards. You don't need to call a data scientist to apply these kinds of techniques. Another one that some of you will have seen leverages forecasting directory, and this was forecasting directly. This was incorporated into our non-emergent surgical restarts, and the gray areas that you see here are forecasts that are automatically generated by month, by procedure, by location, so that we don't have to guess what would normal have looked like in the absence of COVID-19. Those forecasts are produced in an automated fashion for us. The next thing we'll talk about is level 2. Within level 2, deploying predictive models, we have very specific tools and a specific process that we can help you with. These are mostly focused on people who are leading change, leading the deployment of models in your organizations. And again, let us know if this is of interest to you. We have a nice use case from Christianacare where they really had a pretty good predictive model in place for their care managers, but it was a black box. The care managers didn't trust it. The leaders didn't know how it worked. It was difficult to get people to use it, and so it's mostly sat on the shelf. And we specifically worked with them to help ensure that everybody understood why the model, well, we built a new model first off, then why it was working the way that it was working, where they could set meaningful thresholds for action and the rest so that they could really maximize their use and drive the greatest value from a predictive model that truthfully was not bad to start. We helped make it better just from a technical perspective, but more importantly, from a trust and utilization perspective, we worked together to ensure that everyone understood what was happening with the model, why it worked the way that it did, and then they could go forth and feel comfortable using it. The next level up is in fact building a predictive model, and one of the perhaps over hoped for, over hyped, not quite sure what the right word is, but it's over something, is the portability of predictive models. And we've actually found most predictive models to have fairly low portability. This is especially true, meaning we can't take it from organization A and just simply plop it in place and have it work in organization B. And an example of that shows pretty nicely in the pop health arena. And we have two organizations we've worked with here, one in the Northeast, one in the Southwest. One is disproportionately Medicaid oriented. The other one has a pretty good mix of commercial Medicaid and Medicare members involved. And they also have different operating models. One provides a lot of care directly and does some care management on the side. The other one is disproportionately care management oriented. They have different data assets that are available to them. And so what we're looking at here is two clients that had similar questions. Tell me who's going to get admitted into the hospital in the next 90 days. Tell me who's going to show up in the emergency department in the next 90 days. Tell me who's going to expire in the next 6 months. And we have the performance of the models as well as the features that were selected in each. And there's a lot on the screen. But what I'll draw your attention to is that there is a fair bit of overlap. For one organization, we have the CDPS score. On the other side, we have the CMS HCC risk score. Both of those are sort of generically available pre-canned risk scores. And yes, we were able to improve on each of those, but we improved in different ways. And the organization on the right-hand side, they had lab values. So we really did know what people's white counts were and magnesiums and everything else. And it turns out that some of those lab values were actually quite helpful. On the left-hand side, we didn't have that information available. We didn't know what the actual lab values were. But on the left-hand side, we had a fair bit of social determinant data collection, including, for instance, whether or not members needed help preparing their meals. So that turned out to be very helpful. And on the right-hand side, we didn't have that information. On the right-hand side, we had the client did both Medicaid, Medicare, and commercial, and that turned out to be meaningful for risk. Whereas on the left-hand side, it was disproportionately Medicaid. So we routinely see within our clients that two things are true. Models are not particularly portable across clients because there are different populations, different definitions of the outcome, different data availability. But the other thing, and this is the good news, is that it takes us very, very, very little time to build a predictive model. And the process that you need to go through to make sure that you should deploy this predictive model, you essentially get the building of the predictive model for free. So please don't let that be a barrier to you. Level 4, this is the retrospective analyses. And again, this was an area that Sadhika was talking about. And she mentioned, and many people have the perspective on, one of them, the gold standard is the randomized control trial. But there are a lot of cases where we can't do randomized control trials. This is a wonderful example, which you can get in the slide deck if you're interested, looking at how it is that we tie surgical volume to the quality of the outcomes. And this is not something where we could really imagine sending patient A to a low volume surgeon and sending patient B to a high volume surgeon and then just crossing our fingers and seeing how things go. But we can apply reasonable methods, as we did with the Touchstone data to help FDA understand some treatment patterns. We can apply reasonable methods to help us draw some actually pretty powerful and useful conclusions. In this case, helping set, sort of helping to understand what a minimum case volume looks like in different types of surgical procedures to ensure that we can get the types of quality outcomes that we would like to. The last level that we mentioned was that prescriptive optimization, and this is sort of the land of the randomized control trial or something like it. And I just want to highlight something that maybe you all can remember, or if not, please know about it. The Camden Coalition did some wonderful work looking at how to wrap social factors around, social support around their members to prevent inpatient admissions. And I can remember being incredibly excited about this in the 2010s being sure that this was really going to be a major driver of reducing admissions in these vulnerable members. And someone finally took the time, and it's been published now in New England Journal, took the time to measure what happened. And what we see here in these dark bars are the inpatient admissions for a set of members before the intervention, and then the dark bars showing the 40% decline in inpatient admissions once they had the social services wrapped around them. The only problem is we actually had a randomized control group, and guess what? They showed exactly the same ramp up and exactly the same decline, despite having none of the social determinants addressed with the services that the Camden Coalition had advised. And so what this helped us understand is that, in fact, the specific deployment of services as provided here actually didn't make a difference, which you might say is terrible news. And in some sense, it is terrible news. I know I was very disappointed. But at the same time, really good to know that so that we can think about how it is that we want to change going forward. Here's our roadmap. The part that I'll focus on most is at the top, because I'd like, especially for people who are technically oriented, to know that there are a host of capabilities in that guided analytics section that are available and increasingly becoming available to you. You can wrap these into SAM Designer. You can start to wrap these into your standard BI tools. You can wrap these into products like care management or patient safety and others as we go forward. So we have now APIs for the time series outlier detection that we mentioned. We have forecasting available via APIs. We have the statistical process control available via APIs. And so as clients, you have that ability to speak with your account teams and figure out how it is that you can incorporate these things into your work now. Leading wisely is perhaps the easiest and best way in the short term to start to work with this, or in SAM Designer itself. In the predictive space, if you work with us to build predictive models, we will be happy to leverage the tools that we have that we talked about earlier to make sure you understand how these models work and how to feel good about deploying them and how to deploy them and how to measure whether or not they're having the impact that you hope. Within the COVID-19 space in particular, everybody in the world has access to our freely available Capacity Planner website. But please know, as clients, you have the ability to directly integrate our APIs around infection spread so that you don't have to wonder, has the doubling time or reproduction number changed in our area? It can tell that to you directly because we've implemented those algorithms for you. And you'll also see we start to offer more services. And I'll talk about that next, but we are looking for clients who are interested. If you've already decided that you wanted to hire a data scientist or replace a data scientist or augment your team, we do offer services directly in that respect. So if you would like to bring a smiling data scientist into your group, this is a picture from HAS last year, our team at the time. We would be thrilled to get to work more frequently, more consistently with you. It's what gets us out of bed every single morning. And we'll stop with this slide in case there are any questions, but these are some of the typical types of questions that we have been asked and been addressing with clients in this year, 2020. This has been a weird year with respect to COVID-19 and everything else. I happen to be in Los Angeles. Yesterday or the day before, we learned that kids will not be going back to school physically, at least until 2021, which is kind of a shock. Hopefully you're in a place where you're not experiencing those kinds of things. But for as long as we're experiencing these or any of the other challenges that you may have, we would be thrilled to come in and help you figure out how it is that you can ask and answer questions better with data. And I'll stop there.
All right, thank you, Jason. Anne Marie, can we go to questions?
Yes, so Jason, we do have a question from Ken Long. He asked there are a couple embedded. Do you find using tools such as the Johns Hopkins ACG useful in creating predictive models? And what experience have you had using ACG with your clients?
Absolutely. So you can't really see it here, and sorry for that, Ken, but one of the standard tools that we use in building predictive models takes in all of the possible contributing features that we may have, and in the pop health space, which is where we most commonly use ACGs, we will routinely ingest 508 different possible features, including social determinants, either vended or captured internally, ACGs, HCCs, DXCGs, picket. And one of the standard things we'll do is tell you what is contributing most to the different outcomes that you're interested in. And the shortest answer to your question, Ken, is yes, we have found that ACGs, when clients have them, are actually quite helpful for inpatient admission, ED visits, and I can't remember actually about mortality. I'll have to double check on that. But yes, they are routinely helpful, and then we can typically improve upon them with other data assets that you may have, whether those be labs, other specific diagnosis, social determinant data, whatever you have. It's just part of the standard evaluation that we do to figure out which elements contribute the most within your setting.
Great. Thank you, Jason. That's the only question we have, Paul. Jason, I don't know if, Paul, I don't know if we want to give him his 3 minutes. I think Jason had a screen that we could talk a little bit about COVID.
Yeah, let me show you. I just want to make sure that everyone knows that we have available to you the ability to directly via API as clients ingest infection and infection spread data for COVID-19. This is something you can sort of do in the words of IHI by next Tuesday if you want. And what we're looking at here, so this is just the general website. Everybody in the world has access to the website. It's there for free, but as clients, you have the ability to ingest the data via API however you would like and make them visible wherever you would like. I'm just showing here for New York City, Los Angeles, Dallas, King County, which is where Seattle is in Washington State, and Salt Lake, how it is that the infection counts have changed. The daily infection counts have changed each day. The yellow shaded region is showing the forecast for the next 30 days. And then this is actually the forecast line that we see here. And you have different options that you can use. We have different forecasting techniques, different measures of spread. But what you'll see is that actually the techniques that we have done reasonably well at forecasting how the infection spread has changed in your local geographies. You can also combine geographies if you wanted Los Angeles and Riverside, or if you live in the Northeast where there are a lot of counties very close to each other. You can copy and paste and put together whatever geographies you would like and benefit not just from the raw numbers, but actually having the forecasts, having reproduction numbers, having doubling times automatically captured, calculated, and returned to you wherever you would like in the system. This is just a standard thing that's out there and available to you now. So you don't have to wait if that's of interest. Just speak with your account teams and we'd be happy to help. It's a foot in the door for data science and more than happy to take that step with you.